Go for it.
Good afternoon, ladies and gentlemen. We'll be beginning our presentation here shortly. We do ask that you please kindly take your seats. We'll get ready to start in just a few moments. Thank you.
Good afternoon. I bet you guys can hear me, right? Well, welcome. I'm Judy Belk from the California Wellness Foundation. Special thanks to those of you who are in the room and are joining us in this beautiful setting at the Cathedral in downtown Los Angeles. But we also want to provide a big shout out to those of you joining us on the live stream. It's really my pleasure to welcome you to this important briefing. This is a long time coming, and I know those of us at Cal Wellness are really thrilled. You know, we're really here today for one single reason. We all care about the health of Californians and the need for a skilled health workforce. At Cal Wellness, the California Wellness, and I know there's some grantees and some honorees in the room, we believe that healthcare is a human right, regardless of race, immigration status, place, economic level. But having that vision, we believe you also have to carry it out by having a healthy workforce that reflects the diversity of our state population and that provides culturally competent care. But there's another link to our mission that we don't talk a lot about, and that is until we have universal health care in this country, and I hope it happens in my lifetime, most people in the state and this country will continue to get health care coverage through their workplace. So this link between jobs and career ladders, yes, will help us have the workforce we want, but it will also play a huge role in terms of economic health and security. I've always felt that one of the most important aspects of our work, an asset in addition to the resources that we have to give out, is that this foundation is based in California. California has proven its leadership in the rollout of the Affordable Care Act, and it has proven to be a state that knows that we all have to work together to bring about the change. And I think the work of this commission reflects that. First, I want to give thanks to my philanthropic colleagues who joined Cal Wellness to fund the commission's work: the California Endowment, Blue Shield of California Foundation, the California Healthcare Foundation, and the Gordon and Betty Moore Foundation. But a little secret in philanthropy is we have the easy part. We just have to fund good people doing good work and get out of their way. And we did. We didn't serve on the commission, but boy, did we have some leaders who really did the heavy lifting. Janet Napolitano, president of the University of California, and Lloyd Dean, CEO of Gibboney Health, really provided amazing leadership. They led a group of 22 experts from across the fields of health, education, and labor. Folks who came together, putting aside their self-interests for the collective good. They came up with a workable plan to get us there. This is a plan that can improve the areas that we want to improve in the workforce. It's shared ownership. And it won't be easy, but it's doable. And it's going to require the participation of government, philanthropy, health sector employers, education, health plans, business, and community advocates who's going to hold us accountable. This is the second of 3 briefings because we really wanted to be transparent and really engage the community. There was a briefing in Sacramento, and after today's Los Angeles event, the final briefing is scheduled for next month in Fresno. I'm personally particularly thrilled that our focus today is on behavioral health. You'll hear shortly from several of our commissioners, Hector Flores, Liz Gibboney, and Patrick Courneya, along with other respected experts in the field. It's like a blue ribbon committee talking about behavioral health. As with most healthcare, we talk about it as a big policy issue, but it's really personal. And I know for me, I've had to access mental health services for myself and my family, and it's been vital to my own health and well-being. And I know from my own experiences that communities of color are often underserved and under-resourced, especially when it comes to behavioral health care. So here in Los Angeles, a recent Kaiser Family Foundation poll found that nearly 60% of respondents said this region lacks enough mental health care providers. This is higher than other parts of the state. Improving access to behavioral health is just kind of one of the many recommendations. And you'll be able to download the recommendations. Those of you who are here today have copies. And we hope that really by looking at the workforce need that we'll be able to push for more competent, not only behavioral health care, but also other health care for throughout the state. So now I'm going to do what I said earlier. I'm going to get out of the way and turn the microphone over to Dr. Hector Flores. He is chair of the Family Practice Department at White Memorial Medical Center. He served as a commissioner on the workforce and is co-chair of its Primary Care and Prevention Subcommittee. You can find his bio of him and all of our other distinguished panelists in the materials. We have a special fondness for Dr. Flores at Cal Wellness. We've known him and his work for a long time, and he received one of our distinguished awards. You're in for a treat. I thank you for being here, but just remember, today just is the beginning. We're going to need your support to push out the recommendations, hold government and others accountable, and push for why we're all here. Quality health care for all Californians. Thank you.
Thank you very much, Judy. We're really pleased that Judy was willing to open our discussion today, and we also have one of our other funders, Dr. Peter Long, who will help us wrap up and create the book of all knowledge, right, Peter? No pressure. I think we're all going to sit down as we give our presentations. I think it'll just be easier for this to flow. Very, very happy to be the moderator for today. I get to kick off a little bit of the background to our work as a summary before we have our speakers weigh in. I'm really pleased to be here with them, and I'll introduce them now in the interest of time in the order that they'll be presenting, so it goes from my immediate left. The first speaker will be Dr. Charles Alexander, who's the Associate Vice Provost for Student Diversity at UCLA. And for those of you who know him, he's been a long-time champion for diversity in the health professions and excellence in their training. So I want to thank him for being here today. Next will be Liz Gibboney, who is the CEO of the Partnership HealthPlan of California. She's also worked as a commissioner and was co-chair of the Behavioral Health Subcommittee. So we thank her for being here as well. Next will be Dr. Patrick Courneya, who is the Executive Vice President, Chief Medical Officer for Quality at Kaiser Foundation Health Plan and Hospitals. He's also served as a commissioner and part of the Behavioral Health Subcommittee. I want to thank him for being here as well. Next, we have Dr. Bruce Chernof, a longtime friend, who is President and CEO of SCAN Foundation. He's a member of the Healthy Aging and Care for Older Adults Subcommittee. And again, for those of you who know him, he's had a distinguished career serving mainly the people of Los Angeles. His previous lives, he was a HealthNet CMO. He was also director of the LA County Department of Health Services and knows this community really well, and we're really pleased to have him here today. And then our last but not least, our last speaker is Dr. Joanne Spetz, who's Associate Director of Research at the Health Force Center at UCSF. And she's a member of the Technical Advisory Committee, and she's been kind enough to really help us get a perspective in her presentation on the impact of our recommendations. So we'll go on to the next slide and begin to describe our work here. And I have to give credit to Mr. Jeff Oxendine and Dr. Kevin Barnett, who are not here today. They did a fantastic job of doing the heavy lifting to help us put this, actually have the commission do its work and putting the report together, especially the final report, and provided a lot of expertise on their own right. So I want to thank them. And I also want to join Judy Belk in thanking our two co-chairs, Janet Napolitano and Lloyd Dean, for the great work that they did. So I want to highlight some of the good news first. We believe that our recommendations, especially the top 10 priority areas, will get us to where we need to get by the year 2030 in terms of meeting the workforce needs and becoming a template for enhancement of that availability into the future. We can also believe that we can specifically eliminate the primary care shortage and nearly eliminate the shortage of psychiatrists and behavioral health specialists within those 10 years. Our commission's work covered almost 2 years, and it was guided by 3 key strategies. Number one was to increase opportunities for all Californians to advance in the health professions. Number two, to align and expand education and training to prepare new health workers to meet California's healthcare needs. And number 3 is to strengthen the capacity, retention, and effectiveness of the existing health workers. Ultimately, we make 27 recommendations, but as you know, we all struggled because we had over 100 recommendations when we first began to synthesize this final report. So as we like to say, we left a lot of good stuff on the cutting room floor. but we believe that these are the 27 high priorities, and particularly the 10 that we're going to highlight today. We encourage you also to take a look at a glance handout as I walk through these 10 recommendations. First and foremost, it's the pipeline. So number one, our first priority recommendation was to expand and scale K through 16 pipeline programs that recruit and prepare students from underrepresented and low-income backgrounds for health careers. We know that along with the classically defined underrepresented minority groups, there's also low-income white students and their families who are underrepresented in the health professions, particularly in rural communities. Number 2 is recruiting and supporting college students, including community college students, from underrepresented regions and backgrounds by establishing a California Health Careers Opportunity Program. So it's once we identify them through a pipeline to actually give them the enrichment that they need. Number 3 is supporting scholarships for qualified students who pursue priority health professions and commit to work in underserved areas. Number 4 is sustaining and expanding the successful and exemplary PRIME program across the UC campuses. For those of you who may not be familiar with PRIME, it's a program that started in 2004 at UC Irvine, dedicated to enhance the training of medical students to become experts at understanding the policy issues that affect Californians, particularly those that are underserved, and to give them an extra year of training to provide them the leadership skills that they need to be change agents across the state. So it's a great program that is definitely worthy of expansion. Number 5 is expanding the number of primary care physician and psychiatry residency positions. Number 6, recruiting and training students from rural areas, which is a critical need across the state. Number 7, maximizing the role of nurse practitioners as part of the care team to help fill gaps in primary care. Number 8, establishing and scaling a universal home care program with career ladders and associated training in anticipation not only of the aging of our population, but also the frailty among younger members of our society who will need supportive services in the home setting and in the community. Number 9 is developing a psychiatric nurse practitioner program, again, to address the critical shortage of behavioral medicine services. And number 10, scaling the engagement of community health workers, promotores, and peer providers. Our 3 priority areas in terms of beginning to organize our thinking were related to the 3 subcommittees that we mentioned. One was primary care and prevention. The second was healthy aging, and the third was behavioral medicine. Today we're going to be focusing on behavioral medicine. And what I like about the commission's work is that it started with, let's look at our pipeline and their own well-being. So it's basically saying charity begins at home. If we're going to be encouraging hundreds of thousands of young Californians and reentry adults into the educational system, we need to assess and make sure that they are on the road to their own well-being and healthy professional practice. What you're going to be hearing about today is how we synthesize all those components, obviously then looking at the workforce that will serve all Californians. So all of this is quite a list, but when we looked at this, part of what we felt was our obligation was to define how much it would cost to deliver this on this promise. And we calculated that for the 10 top priorities, it would be about $3 billion over 10 years. It's a lot of money, for sure, but if you think about $300 million a year over 10 years to add up to $3 billion, it's 0.1% of what we already spend on healthcare every single year. And as an employer who buys insurance for our workers, if somebody came to me and said, if for every $100 you are paying for health, would you contribute $1 for that? I say absolutely yes, because it makes it worthwhile to buy a product when my employees and their families are going to have access. So it's not a difficult math solution to come up. Number 1, we want to grow and support and sustain California's health workforce pipeline by reaching over 60,000 students. This is a big, ambitious goal, but we believe it can be done. Number 2, increasing the total number of health workers by over 47,000. All of them will help deliver care that is better, faster, and cheaper. Number 3, improve diversity in the health professions, producing approximately 30,000 workers from underrepresented communities, and increasing the supply of health professionals who come from and train in rural and underserved communities, and training over 14,500 providers, such as physicians, nurse practitioners, nurse midwives, and other professionals coming from underrepresented groups included in that number. So now I'd like to ask my colleagues to share their views on this, and we'll start with Dr. Alexander.
Okay, thank you. Thank you, Dr. Flores. First of all, let me just thank the commission, members of the commission, and all those who have supported the work of this incredible report that you all have in front of you today. And I just wanted to say a few things as it relates to the gaps and the need and the pipeline that the commission report addressed. And it's funny because I'm sitting here in 2019 when in 1980 I was talking about the same thing. Doesn't seem like much has changed. There's been ebbs and flows in the applicant pools of all these health profession schools and programs, but nothing very constant, or you don't see rises in the numbers as we had expected back in 1980. And so here we are in 2019 talking about increasing the workforce, addressing the needs of the public, and also providing access to care for vulnerable populations. You know, what I do at UCLA, I think, is important work, and we all do important work. And I chose to come to UCLA because it's one of the few public institutions where you have a third of the student body that's from underrepresented, low-income, under-resourced communities. It's a place where students have an opportunity for a chance in life that improves not only their community, but also their families, which is very important. And not only that, but they have one of the highest applicant rates to health professional schools in the country. And so what a fertile ground for us to work in and to try to recruit students to go into the health professions. A lot of students do have an interest and they major in subjects that will lead them into the health professions. But I think more importantly that I want to talk about is how this pipeline that we've been working on for many, many years sometimes has clogs. You know, we hit certain points in terms of we prepare students to get into the health profession schools. I should even talk about college, but I won't say much about college because we all know what's going on in the college world today. But we do a lot of work to prepare young people to go into these professions, starting at the, I would say, K through 12 level. We need to make more investment in that level to even begin to attract students into these fields. There's a lot of competition for careers out there, and a lot of them have tags on them, dollar tags on them, unfortunately. But the ones that are meaningful and the ones that can make a huge difference in our communities are the ones that we're talking about today, to save lives, to change communities, to change the way that people access care. And so the work that I do, I try to develop more pipeline programs. I started at UCSF when I came to California and had some really great programs going on, and some of the colleagues in the room know that. And some of them are grant funded, some are foundation funded, but the sustaining of funding is so critical to these pipeline programs. We won't see these demographics change in the health care providers if we don't sustain these pipeline programs. That's where the workforce is coming from, and particularly the workforce for people of color. There's also another point I want to make here too, is that when you look at the population of California, particularly one startling fact that stuck out for me was the 41,000 clinicians that we'll need to address some of the primary care needs. But when you think about, you know, Latinos being 40% of the population, nearly 40%, and only 7% of the physicians workforce out there, that's mind-boggling when you think about these great universities, colleges, community colleges, I mean, places of higher education that we have that have been in this business for a long time, but yet we have not made a dent in that population. And I could say the same thing about the other groups, African American, Native Americans, Southeast Asians. I mean, it's very small numbers that we're producing. We need to do more in terms of expanding class sizes for some of our medical schools. I know they're at the gills in terms of raising the numbers, but it's not just raising the numbers, it's also about who they're letting into these medical and dental and health profession schools, nursing schools, and so on. There needs to be more done. And we all know what devastated that back in 1996, I believe it was. And we're still paying the price for that. And we'll continue to pay the price for that until something significant changes. But I do think that the work that the Commission has laid out for us in terms of a beautiful blueprint that will help us go down this road in the future. And I'm always skeptical about these reports. You know, we've seen many, many reports. But I have to say that, you know, being a part of this process, I too was on the Technical Assistance Committee, Advisory Committee, but being a part of the process and seeing the many, many people from across the state invest their time and energy and their brain power in terms of a plan and a strategy to see this come to fruition, it's just amazing. So I have hope. I have hope and promise for such a report going forward. Let me just kind of wrap up and say, you know, the bottom line is that we're going to we really have to work hard in the next 10 to 20 years. I was looking at some data that said something to the tune of our state changing complexion drastically in 10 years, but yet our provider workforce does not reflect the state population or nowhere near the people that we're talking about who are being impacted greatly out here in our great state of California. This is why recruiting students, this is why these pipeline programs are so important. The workforce is really coming from the communities that we all are a part of and that we all want to serve. But we really have to work on attracting, retaining, and graduating these students from these health profession schools. There's some great models out there in terms of loan indebtedness, payback. NYU, you probably heard about taking care of medical students, because it is the finance that makes the decision about where they go practice and do the work. And if somehow we don't address that particular issue as well, then we're going to continue to see the price tags on these careers, in these competing careers, that are going to keep young people, and particularly people of color, from pursuing the kind of careers that we really need them in, and that's these health professions. So let me just kind of conclude by saying that, again, every time one of these students go into the health profession field, they're not only ensuring the health of the patient, but also the health of themselves and their families. And so this is so important, and the commission, as I mentioned before, has really given us a great framework for helping to address this need. So I appreciate the opportunity to be here and to share a few remarks on this topic, and I look forward to working with my colleagues and challenging you all out there in the audience to step up and help in this great cause that's been presented to us today. Thank you.
Thanks, Charles. Liz? Good.
Okay, just need to be closer. Good afternoon. My name is Liz Gibboney. I'm with Partnership HealthPlan of California, and that is a local nonprofit health plan in Northern California. How many of you have been to Modoc County? Awesome. I'm buying you a cookie. Modoc County is the top right-hand corner of California. It's our most rural county in our service area. We cover over 500,000 Medi-Cal recipients over 14 counties. So my comments today are really from the perspective of learning from communities about what their needs are and trying to provide care in other ways to more expeditiously meet their healthcare needs. We know from many surveys that behavioral health is one of the top concerns, if the not top concern, among Californians as it relates to healthcare. And we see from local health plans, organizations like mine across California, we see how hard it is to provide service to folks who do need behavioral health care, especially when there's a shortage of providers in our local communities. This ranges not just from child psychiatrists, but to peer support workers who are often on the front lines and can help folks get access most immediately. We know that most people who do need treatment don't get it, and you'll see from the slides behind me, family members struggle daily to help their family members get into care and to get the services they need. At least in our service area, many of our members and others in the community have to wait many months and have to drive or get transportation for long distances to get the services they need, and that can often lead to a deterioration in their healthcare status as they wait for care. We do know that many communities lack the resources that support the decision to even seek treatment, for instance, for drug treatment services, including outreach workers and peer providers with lived experience who live in the local communities and can be on the front lines to help community members decide to enter treatment or to get care, especially when there's so much stigma still surrounding the types of services that we're talking about. There are geographic areas within my own service area in Northern California where clients have to drive several hours just to get detox services or medication management services in order to begin the treatment that they really need. And in many cases, these services, if we were able to enhance them through greater training for physicians and allowing certified drug providers and peer providers, those needs would be met much quicker and in a much more local fashion. Now, rural providers are incredibly resourceful people. The rural north, at least, is extraordinarily beautiful, and I am in awe with what our providers in the northern region are able to do with the training that they have. They have many challenges in trying to reach our members and others in the community. And in some cases, with additional support and additional training, they would be able to do even more than they currently are able to do. Not surprisingly, health plans like mine have employed telehealth as one tool in our toolkit to help reach individuals in remote areas. It's not just for remote areas anymore. We're seeing telehealth used much more in suburban and urban areas. But some behavioral health treatment modalities don't really lend themselves to telehealth, so we can't count on that alone as a way to improve access. We do know that from our work on the Behavioral Health Subcommittee, and I want to thank the 25 or 30 folks who served on the Behavioral Health Subcommittee, we really tried to balance the needs across the state, since there is an acknowledgement that there is a shortage across California. But in particular, there are geographies where this need is even more acute. I'll say here in California, even though we're right in the middle of a very busy downtown neighborhood, LA has rural areas, as we know, and it is difficult to experience care even in LA County. In our northern region, as we call it, some of our communities don't have access to reliable broadband, so you can't just say, well, use your smartphone or use your iPad. There is no Wi-Fi to be had, and we know that many of these services can be provided real-time and in the comfort and safety of someone's own home to be able to get that care, and we need to be able to use that as much as possible. We also know and hear regularly, especially from our safety net providers, that competition is fierce among the provider recruitment world. Competition is driven higher, and that's not just met with additional dollars thrown at potential providers being wooed in many parts of the state and the country to come work. It has to be a very comprehensive and statewide strategy to encourage providers to come to California and to stay in California and to work especially in rural communities. The recommendations that are in this report reflect many of these considerations, and we believe that one of the most important parts of the report is the call for more integration of care across the continuum and to stop separating behavioral health from physical health care and to provide as many services as possible together, acknowledging the whole human body. We do need more psychiatrists, as one of the recommendations, I believe it's number 5, focuses on. But there are many other healthcare workers that we've tried to call out in this report that would be instrumental in reducing the shortage that we're talking about. Physician assistants, nurse practitioners, looking at ways that we pay for licensed clinical social workers, marriage and family therapists, and others. They can provide extraordinary services to our members and others in the community, and we need to be able to pay for them regardless of the payer source or the insurance source for the clients at hand. And I would be remiss if I didn't call out the importance of prevention and the cost effectiveness associated with prevention and early intervention to ensure that we catch behavioral health issues as early as possible in our community and get individuals into care as soon as possible. And I'll conclude with just talking about some anecdotes from our service area up in Northern California. We provide the mild to moderate mental health benefit that all health plans covering Medi-Cal do now. We know that between 60 and 90% of our clients who are accessing the mild to moderate mental health benefit also have co-occurring addictions. And so we are doing as much as we can to support those individuals who are currently providing mild to moderate services to get additional training. And that's one of the other areas called out in the report, is giving additional training to folks who are who could provide more services across the spectrum with additional training. We believe that the Commission's recommendations are sound, and if we can support them and enact them, we will see greater access across all of California, and in particular in rural areas that we all enjoy. So thank you very much. I look forward to hearing your questions.
Thanks, everyone, for coming today. It is nice to get a chance to talk about these recommendations and the needs of the state of California on this very important issue after the work of the commission has been released. It's an important conversation, and I too look forward to your questions. We've already heard about the fact that we are living right now with a system that reflects ideas from the 90s and the 2000s that haven't even been fully realized. And it's just not even adequate for the current needs that we have. And the idea that we're talking now about what we need to do over the next 10 years to try to meet the needs of the residents of the state of California is bold, it's important, and it's very challenging. The idea that we need to make investments is clear. As a family physician with over 2 decades worth of experience taking care of patients in an environment where I recognize the value of integration of behavioral health services in the primary care setting, and as a family member with lived experience, have very, very clear understanding of the impact of an inadequate system for the provision of mental health services, the lack of availability of professionals to help support, and even the lack of the kind of community resources that are necessary short of professional care for mental health conditions that really help to create an environment where the residents of a state like California can hope to thrive, that they can hope to bring together health of body, mind, and spirit to be able to be the parent and the partner that they want to be the coworker and the community member that they aspire to be, and to be the family member and the friend that they want to be. Mental health is an important characteristic, it's an important asset for all of the residents of the state of California to be those things as they want to be. And unless we can create an environment where we recognize that and we train the professionals that we need to help ensure that, we're going to really miss the mark and fall short of what's necessary for the state of California. For our own organization, Kaiser Permanente, which is where I practice my profession, our growth in the demand for mental health services has increased since 2015 by 35%. And that's far outpacing our own growth in membership, and it outpaces our growth in workforce to be able to respond to that need. Now, you can look at that as a positive thing in that people are perhaps recognizing that stigma no longer needs to be a barrier to seeking mental health care. And you can also see it as the benefit or the consequence of mental health parity when it comes to coverage of services. All great things. But that increasing demand is being realized in the context of, as we said before, an environment that was inadequately designed decades ago. This commission report is a response to that very important need. Addressing those mental health needs requires that we anticipate changes projected for the state of California. It recognizes that change is happening rapidly, both in the way we deliver mental health services, the way we understand the needs of the mental health folks suffering from mental health conditions. And also, it recognizes the very rapid change in all other sectors of society and the economy that add to the stress that we're living with, add to the complexity of the response that we need to create, and add to the demands that we have for supporting proper mental health care. We need to really invest that time and energy now to be able to create the workforce that's necessary, and we also need to be able to respond to the opportunity that we have to make sure that the mental health professionals that are available in the state today are able to operate at the full extent of their license so that they are delivering the services that they're capable of delivering to everyone that they might benefit from. Expanding that capacity immediately is, I think, the compassionate thing for us to be able to do in response to that need. The idea that overall health requires health of mind, body, and spirit is something that really has come through to me in my own career, recognizing that those three things together make it easier for people to actually follow through on their day-to-day choices and their day-to-day intention to take good care of themselves. it has been very easy for me to recognize that someone who is struggling with mental health conditions, a very stressful environment, has an especially difficult challenge following through in those things that we all face as challenges day to day, making good choices for our physical health, making good choices about the plans that we make in partnership with our healthcare teams to improve the health that we have, to treat those conditions that we come up against. And in the context of struggling with a mental health condition, that's made even worse, made even more difficult. So we know that those things are connected together. And the idea that this commission focused specifically on those needs, I think, is very important for us to recognize. It can have a dramatic impact on the state of California and the residents of the state of California, making families stronger, making our communities safer, stabilizing jobs and businesses, and when done right, can improve the outcomes of those other conditions, the physical conditions that we also recognize are important for us to fulfill our desires and our roles. We can all be really effective partners in doing that, but it does require partnership. And without that, and without the kinds of recommendations you see in this report, we'll fall short again, as we've talked about. There's a particular challenge that we've already discussed that I want to point out. And that is substance abuse, and recognizing that it presents a particularly serious and acute problem for the state of California and the country as a whole. The healthcare profession itself needs to recognize its role in reducing the impact of the decisions that are made in the way we use narcotics and other medications, and the impact that that can have on the availability of narcotics in the marketplace and on the risk of developing addiction. And we also must stand ready to be able to help support addiction recovery, making sure that we have the workforce and the programs and the finance models to be able to do that effectively is critically important. And that makes addiction recovery services and the training of those professionals a priority and a focus for now and the current and the future. It's important also to recognize that in order for us to really be effective at doing that, at integrating mental health support, addiction recovery support into primary care, into the rest of the medical environment, we need to have greater freedom to communicate with one another about the needs and challenges of the patients that we are serving. And being able to address barriers to effective communication and support of that care is critically important. There is a tremendous opportunity for California, as it always has been, to take a leadership role and serve as a model for the nation in how to accomplish not only the future health workforce needs, but in supporting our residents' mental health and overall health goals. We have to build that pipeline. We've discussed this already. We have to make sure that all of the residents of the state of California can see themselves in the future being a part of that workforce and being able to give them the kind of support that they need to realize that dream that they might have. Making sure that everybody who does practice in the state is practicing in an environment where they can practice at the top of their license, where they can take the skills that they've learned from the great training that they get from the institutions of California and serve all of those who might benefit. Having mental health professionals in the primary care setting, I can't tell you how important that is. I have seen it myself in my own work. I have seen the positive impact that it has, not just on the kinds of things that people are doing to address their own physical health needs, but on the life and vitality that they have, that they enjoy, and the role that they play. And the idea that we bring these things together and address those needs effectively is critically important. Non-traditional supports are critically important as well, and that reflects what we have learned about the benefit that people can get by having well-trained peer support people in the community to give people with mental health conditions the insights and the benefit of the wisdom of folks who have that lived experience, and making them a part of the team, as is reflected in this report, is critically important. Another point, and you spoke to it when you spoke about both the dependence on and the barriers to being able to deliver telehealth services. The idea that that is a critically important asset and capability is something that We can't leave any community behind. We also need to recognize that rural communities have those barriers, and when you think about how long it takes to move around a metropolitan community like this, those barriers exist as challenges that we need to address. The idea that LA County has 77 areas that have been designated as shortage areas for mental health care is just incredible, and it's really, I think, pretty disappointing to consider. We should be able to solve those problems. There aren't any real simple solutions, though, of course. It does take an incredible commitment on the part of folks represented in the room, on the part of the state of California, to be able to realize these changes. Educating and training a full array of different health professionals, and mental health professionals in particular, is critical. Making sure that we are building new programs, making sure that those new programs are training folks who then have clinical work environments where they can complete their training. We're starting up our own new medical school, and one of the commitments that we've made is full support for all 4 years of tuition for the first 5 classes. We've also made the commitment, actually in the context of that training, that those individuals understand what is necessary for them to maintain their own mental health and well-being, and by extension what it means to the patients that they will one day serve to be able to address those needs as well. Making sure that they understand the role that team members play in providing the services that are necessary. And also by reducing the burden of debt that can come from that kind of advanced training, giving them the flexibility to pursue the careers that they want to in the first place, wherever that goes, but without the constraints that can be caused by the incredible debt that comes from getting that training. Being able to do those kinds of things is critically important. Being able to create the clinical environments where that training occurs and being able to support that training effectively is important. And I think if we are going to realize that aspiration to have a healthcare workforce and a mental health care workforce that reflects the population of the state, these are the kinds of barriers that we need to address. And these are the kinds of barriers that are addressed in this commission report. We in this room, on the commission, as healthcare leaders, lawmakers, residents of the state of California, educators, and others with a stake in the results of this report, need to come together really to produce the results. The recommendation put us on the right path to recruit and train and retain more psychiatrists, psychologists, and other mental health workers, reflecting the populations that we aim to serve, and to better meet the needs of the citizens and residents of the state of California. They bring us closer to a workforce and a healthcare system that better integrates mental health services with physical health services, that is evidence-based and focused on measurable outcomes. The time horizon for these recommendations is 10 years, but as I said, we don't have time to walk past the things that are around us right now and making available the full scope of practice that the mental health professionals have available now. And we can work to extend and expand that flexibility, and we should. Everyone has a role in letting the decision makers know that this is a priority and that the care of our residents when it comes to their mental health needs is critically important and can't be ignored. We have to do this together. We have to march towards that simple goal, and that is to get more Californians, the care they need and make it better and faster. Thank you very much. It's great to be here. I'm looking forward to your questions.
Great. Well, it's a pleasure to be with all of you this afternoon, and I'm here on behalf of the Aging Subcommittee, which was one of the 3 subcommittees that helped pull together this report. And you might ask, well, why is aging on today's plenary session? And I think the reality is that 2 things are true, right? So one is really listening to the comments we've already heard, many of the challenges we face in behavioral health apply to an aging population as well. So treating the whole person, not just their named or titled medical condition, meeting people where they are, thinking about how they thrive as opposed to just some clinical metrics of outcome, super important, and I think a kind of a shared basis for change. Another thing that you said that really resonated with me was this idea that it's about a team of care, and the teams that we've traditionally built in the past are not the teams we need to be building for the future. And that makes all of us a little bit uncomfortable, but we have to get out of the box to build the system we want. It's not just about more of the system that we have, because it's actually not helping us succeed as the population grows and changes. So I think there's a whole lot of reasons for aging to be up here today. It sort of fits right in this discussion in the kind of challenges about how care is delivered. But frankly, older adults face all kinds of behavioral health problems that are often or underdiagnosed and undermanaged as a result. So this is kind of a warm home for our subcommittee, and I'm glad to be here on behalf of our co-chairs, who were Dr. Heather Young, who's the dean of the Gordon and Betty Moore Nursing School at UC Davis, and Dr. Chris Castle, who actually helped Kaiser begin standing up their new medical school, as well as previously serving as the head of the National Quality NQF, National Forum. So we had some really great committee members, and I'm sort of honored to be here on their behalf. I guess I would just say, as a foundation here in California that's focused exclusively on vulnerable aging, on how do we build a navigable, person-centered system that actually advances independence, dignity, and choice, we feel a little orphaned. We're one of the largest foundations in the country that focuses on vulnerable aging, which is a sad thing to say, because out of the tens of thousands of foundations that exist in the United States, and of the subset of those that focus on health, you can count the number of foundations that focus exclusively on aging, and particularly vulnerable aging, on one or two hands. So it's an area that's sort of under-recognized and orphaned a bit the way behavioral health can be, and I think so, again, another reason why being up here is so important. It's a critical discussion for us to have in this state right now. I think we under-recognize where California sits relative to other states. We're a very young state compared to most states. When you compare us to, say, Vermont or Maine, they're way grayer than we are. For what that's worth. And, and what I'd say about that is we're going to get there. So if we think there's something magic about the water here, that's just not true. And we're really ill-prepared for it. So there's going to be 4 million new Californians that'll turn 65 over the next 10 years. By 2030, 1 in every 5 Californians will be of retirement age. And the world in front of us looks very different than the world behind us. So as baby boomers sort of age into their retirement, they're going to look very different than younger boomers and very different than the silent generation that preceded them. So we're going to see a population of folks who's far more likely to be of color, to live alone, to have fewer resources. They are less prepared. Even the difference between older and younger boomers. What kind of retirement savings do they have? Were they able to bounce back from the Great Recession of 2008? If you are amongst the oldest boomers, you might have some kind of pension or retirement program. Amongst the youngest boomers, that's simply not true. So we have a population of Californians that is going to be far less prepared than even folks 10 years ago or folks 10 years before that. One of the other things I want to highlight for all of you, and I think this is another sort of kindred spirit with the behavioral health discussion we're having, is it's not about a moment in time. So the next time somebody turns to you and says, well, it's all about the silver tsunami, let me ask you to stop in your tracks. Okay, so aging is not the equivalent of a natural disaster. That is incredibly ageist, and I've got news for every single one of you. The only thing I can promise all of you today is it will happen to each and every one of us, including you. So I think, watching our language, sort of how we think about who we are, is really, really important. And then I think, let's geek out for a sec and actually look at the data. And I think the key point here is this is not about the snake swallowing the demographic elephant and we just need to wait and it'll all be okay. Because the reality is the demography of millennials and Gen Xers will look very much like boomers. We're designing the system that we want and need for the next 3 generations. So I'd argue the system we have today was sort of built around 1965 when Medicare and Medicaid were built. If you think about when Medicare and Medicaid were built, ICUs were still relatively uncommon. The number of things that you could actually do in an outpatient setting were fairly limited. I can count the number of blood pressure medicines that were available on maybe 1 or 2 hands. I mean, we're sort of dating ourselves up here. So I'm raising this because we have an environment that's purpose-built for about 1971. We should just hang the disco ball up on the ceiling and let it go. That's the healthcare delivery system we have. And unfortunately, it needs to be brought up to current with where we are today. And the fixed infrastructure, things like hospitals and clinics and whatnot, are still sort of being built in a higgledy-piggledy way, although there's some more effort to make them more organized and work together better. And I think the challenges in front of us are to actually, and the point about we've been at this since the 1990s is depressing. Because what it says is even as we've built more infrastructure, we actually haven't brought the workforce up to current. And I think that's true for all of the subcommittees, not just in behavioral health and not just in aging. So I think the call from Dr. Alexander at the very beginning that we actually need to act on this stuff, like talk less, do more, if that's the most important thing we all take away from this, I'll feel like this was time well spent today. I also think, kind of going back to the last speaker's comments, being willing to sort of say it's not just more of the same old system, because the same old system is really not serving people very well, because we tend to break people down into their parts. I only treat this part of you. The rest of you has to go see the person who treats that part. So this more holistic notion to care is how we actually get to better care at lower costs, better population health outcomes, and frankly, a healthier workforce, right? We want people to be proud that they're part of serving older Californians. So when it came to the aging subcommittee, I would say a couple of things are true. Much of what you've already heard today is very relevant, so there's sort of no point for me to make those comments again, although I've highlighted a couple that I think are super relevant to the work of the subcommittee. And I think, so building a better workforce in general will result in a better workforce for older adults too. We all will need primary care, for example, and better behavioral health. There were a couple of things that really rose to the surface, which are difficult, and I think scratch at the issue of who do we want to be tomorrow as opposed to who are we today, and why is that tough sometimes. And I think we saw a real need to think differently about not just having a fuller pipeline, but what we're asking people in that pipeline to do when they actually enter the workforce and across the arc of their careers. And so 2 really important things that came from this were the idea that we, unlike many other states, we still limit, in many ways, the scope of nurse practitioners. I think one of the things that we need to be super aware of with respect to this discussion about nurse practitioners, and the next point I'm going to want to raise, is to just say that we have shortages and hope it will come out in the wash or we'll just train our way out of it, is to ignore the fact that that's actually not going to work. So training more people is important, but we need to position them in different ways to succeed. And the reality is, with all due respect to the recommendations about physicians, physicians are going to have to get really comfortable with the idea that we need a broader range of frontline providers, and nurse practitioners are a really important part of that. One of the things that's incredibly important to older people is that they can receive care in the community, and that community may be their home. Hospitals are dangerous places for older people. Even when you admit an older person for a proper diagnosis, the evidence is incredibly clear. If they're in for 3 or 4 days, urosepsis, name the bad condition, they will come out at a lower functional level that they will never regain, even when they're properly admitted and properly treated. So if we start with the premise that we want older adults to thrive at